After completing her residency, Dr. Amy joined Knives as our second boarded specialist. Over the past 12 years, Dr. Totten and her team have helped support our referring community and your clients to address a variety of complex medical conditions. So please welcome Dr. Totten.
Thank you. I'm just so pleased to see everybody here tonight, and looking forward to presenting this information about atypical Addisons. I became interested. I do enjoy endocrinology. I am not an internist that has a specific area of medicine that I really have to, I kind of like all of it. I always have. But endocrinology is very interesting to me. I've always been a bit fascinated by it. And this actually came into being because I ended up with a patient with atypical Addisons. And I have had a few over the years. The patient I'm going to present tonight was quite an interesting, complicated process to getting to the diagnosis. And we have a morning rounds session once a month here with the doctors. And I presented this case report to the doctors. So for tonight, I did more investigation into the literature search for Addisons, atypical Addisons, and found out some interesting information. I've actually learned a lot from looking through all the literature and studying about atypical Addisons, and my patient taught me so much, as I'm sure so many of you experience your patients teach you things, as well as your clients teach you things. So I've had a client that her dog has a version of atypical Addisons, and she's taught me a lot too. So I'm going to go ahead now, and I did also want to let everybody know if there's anybody here. I know there's many faces I recognize and know. If there's anybody that we've never met, please come up to me afterwards and introduce yourself. I'd definitely be happy to meet you. So just an overview. So some of the topics that we're going to cover tonight is atypical versus typical hypoadrenocorticism. What is the difference between the two? What are the symptoms? More focused on the atypical, and then how is it diagnosed? There will be a review of the renin-angiotensin-aldosterone system. So I think we all can use a review of that because it was one of those systems that we learned during vet school that probably is not something that we always remember in our minds. And then I am going to incorporate some of the recent review of the literature. There is not a lot of atypical Addisons, but there is some good literature available. I'm going to present a case discussion, and then I'll talk about treatment, management, and monitoring. So just some definitions to cover. Primary hypoadrenocorticism, which is primary Addison's disease. It's an immune destruction of the adrenal cortex. It also could be atrophy of the adrenal cortex. There is that mechanism that can occur. And it's broken down into Addison's disease or atypical Addison's disease. So primary hypoadrenocorticism, Addison's and atypical falls underneath that. Both are diagnosed via the 1-hour ACTH stimulation test. So there will be a low, probably flatlined cortisol pre and post. Addison's disease is going to be deficiency of glucocorticoid and mineralocorticoid. So both are going to be absent. It's very rare to test for mineralocorticoid. That's your aldosterone. So it's very rare to test for that. So I'm going to get into that a bit. Atypical Addison's disease is just deficiency of glucocorticoid only. So basically, one test will test for both, but the atypical comes into play based on the way the lab work presents, and it can be more difficult to get to the diagnosis. In atypical Addison's, like I just mentioned, the mineralocorticoids are considered to be unaffected. As I'm going to present an article, there actually has been some evidence that they might be affected, and it's just not showing up in the blood work. So I just spoke about primary. This is secondary hypoadrenocorticism. Secondary is where the pituitary gland is not releasing the ACTH. So the hypothalamus has to release cortico-releasing hormone that then stimulates the ACTH to be released from the pituitary. And so in secondary, it's not being released from the brain. So therefore, the adrenal gland is not going to be producing cortisol. So this is going to be cortisol, glucocorticoid deficiency only. So this is also another form of atypical Addison's disease. So just a review about the adrenal gland anatomy. So the cortex is divided into 3 layers: the zona glomerulosa, the zona fasciculata, and the zona reticulata. And the glomerulosa is where we're getting our production of aldosterone, the mineralocorticoid. The fasciculata is where the production of the glucocorticoids are coming from. And the reticulata is going to be the sex hormones. And then the middle part is the medulla, and that's going to be the epinephrine. Okay, so how common is atypical Addison's disease? Has anybody here had a patient that they've diagnosed with atypical Addison's? So Dr. Gupta has, and we have another one over here that has also, and another, okay, so about 3 in this room. So the statistics in the literature is, it averages about 30%. There was one case that had a percentage of about 32%. And there was another retrospective study that had about 24%. What we know, though, is that these are universities that have a very high concentration of not typical cases coming to them. So Addison's disease is commonly diagnosed with primary care veterinarians or emergency facilities. And so these cases that are at these universities are being referred because they're just not presenting themselves like a usual case would be. And so then through their workup, they're figuring out that they're having atypical Addison's. So these statistics are probably skewed. So it's probably not 30% of hyperadrenocorticism cases. So, but that's what's in the literature, so that's why it looks that way. But in most of these studies, in the discussion section, they'll comment that this data may be skewed because of the population that they're selecting for. So symptoms of atypical Addison's disease, they're very vague. The most common symptoms are gastrointestinal symptoms. And these are usually dogs that have waxing and waning symptoms. So decreased appetite, usually losing some weight. Maybe they're having some inability to gain weight, mainly linked to the fact they don't eat enough calories. Usually vomiting and diarrhea, which can affect their weight. They also can have some very vague lethargic symptoms, and they can come and go. And then also they may not have any symptoms at all. They may just really cover this up and not show their owner or the veterinarian that they're having any problems. So this is a retrospective study that was done at the University of Minnesota looking at records over a 10-year period. So this is one of the more recent studies on atypical Addison's in the literature. This was in a Journal of Small Animal Practice from 2017. And this looked at 39 dogs, and the most common symptom was lethargy. So I have to say, personally, if I had an owner presenting to me and saying my dog is lethargic, I'm probably not going to immediately think, oh my, this dog must have Addison's disease. I'm going to have likely multiple other things in my mind before I move to Addison's or atypical Addison's disease. Chronic clinical signs, which can be very vague, was 69%. Vomiting, 64%, weakness was 26%, abdominal pain was 10%. These dogs can be PUPD, and that was 3%. And then a little bit higher over on the anorexia, diarrhea, hematochezia, and weight loss categories. Like I mentioned, those are very common symptoms. And then some dogs can have melena, so you can have a hematochezia or melena. You can have hemorrhage anywhere throughout the GI tract in these cases. And then there's 8% of cases that, which equal the number of 3, that had routine health screening that led to this. So they had done some general blood work, and there were some changes on the blood work that ended up helping get to the conclusion of the animal having atypical Addisons. Is Andrea? Where did Andrea go to? Okay, so on blood work, this is where we can start to try to pick up some of the subtle abnormalities.
Did you get it figured out?
The advancer, this is mine, if I could use yours. I think the battery must have just gone. So these dogs do not lack mineralocorticoid. They have normal aldosterone, we think. But we might, as we go on, we might learn that they don't always. So usually though on their blood work, their sodium potassium is normal. They don't give you those clues. They don't show the high potassium and the low sodium that we typically look for our Addison's dogs. The most common chemistry abnormalities is hypocholesterolemia, low cholesterol. This was a learning thing for me. I had no idea atypical Addison's dogs had low cholesterol. I get patients back with low cholesterol in their blood work and I think, well, I'm not worried over that most of the time. And then the other common chemistry abnormality is low albumin. On their complete blood counts, they typically have some form of anemia. It's usually pretty mild, so a hematocrit of somewhere between 30 to 33%. And their white blood cells, they tend to have a lymphocytosis, and they also can have an eosinophilia. And they could also just have a normal complete blood count. So there may not be any changes at all to give us any ideas. So this was the University of Minnesota study, that 10-year period, the retrospective study that was published in 2017, looking at blood work changes in these dogs. And hypoalbuminemia was the #1 symptom, or #1 blood work change at 87%. Low cholesterol was second at 76%. They had an increase in AST in their patients. I did not run across this abnormality in other cases that I've looked at in the literature, but this university had a 43% change in that liver enzyme. Hypoglycemia at 35%, lymphocytosis at 33%, anemia around 28%, neutrophilia. So we tend to think that a lot of Addisonian dogs won't have a stress response. And a stress response being a neutrophilia usually is included in that, but these dogs had a neutrophilia. 26%, and then eosinophilia at 21%, increased ALT 18%. I would have expected ALT to have been up there with AST, and there was really no remarks in the paper as to why the difference. Increased BUN and increased ALP phos, and then lymphopenia were the lower ones. This just doesn't work. So, imaging, what might we find on imaging? What abnormalities might be able to be detected? Megaesophagus might be seen. That is known to occur with Addison's. It can occur with atypical Addison's disease. And then abdominal ultrasound can give a clue if the adrenal glands are small. Typically less than 0.32 centimeters of the width of the adrenal gland. Also, it may be difficult to find the adrenal gland, so that could start to give some clues. It's not going to give it the diagnosis, but it could give some clues. So in the Journal of Veterinary Internal Medicine in 2014, there was a recent study looking at aldosterone concentrations in dogs with hypoadrenocorticism. And part of this study focused on atypical Addison's disease. So what I've already discussed is that these dogs should have normal aldosterone. Their sodium and potassium should be normal. the zona glomerulosa of their adrenal gland should be producing the aldosterone like normal. So that's the assumption. But this study kind of took the perspective of how do we know that? Because it's really rare to measure aldosterone in these dogs. We're doing an ACTH stimulation test, we're finding their cortisol is low. That usually is the end point. We have a diagnosis, so why would we go further and measure aldosterone? But they just took the approach to say, well, let's look further into this. So what they discovered is that aldosterone levels were low or undetectable in most dogs with Addison's, and it was independent of their degree of sodium and potassium changes. So they could have had normal sodium potassium on their blood work, but had low aldosterone levels. So then it led to some theories as to why this might be occurring. So how can sodium and potassium be normal if aldosterone is low? And this was helpful in a way to me, first off, because it allowed me to review the RAS system, which I'm going to do here shortly. And it also made me realize that one of the patients that I have been seeing for a couple of years that is a proven Addisonian patient, also a proven low aldosterone dog, so a true Addisonian, because I did aldosterone levels, because this dog's electrolytes went back to normal after the first per-quart injection, and they stayed normal for months. And the owner was concerned the dog didn't tolerate the first per-quart injection well, which there's no scientific evidence as to why the dog wouldn't have tolerated it. But the owner just felt that it just caused some problems, so she didn't want to give another. And since the sodium potassium stayed normal, the decision was made just to kind of monitor the dog, but keep it on a very low dose of prednisone. And since I read this study, it made me realize that that dog probably is one of these dogs that we've proven has low aldosterone, that potentially the dog could have been diagnosed as an atypical Addison's, but it truly is a full Addisonian. So now we are going to review the RAS system. Is this anybody's favorite area? All right, so the RAS system involves the important area in the kidney called the juxtaglomerular apparatus. The juxtaglomerular apparatus is including the afferent arteriole, which this is the glomerulus here. I think the reason why this drawing is not just nice and simplified with the tubules just coming down and going back up is because it's trying to show how everything comes in contact with each other. So the afferent arteriole that goes into the glomerulus comes right into the area here where the distal tubule is. And that area, there's cells there that help in detecting certain hormones and electrolytes and releasing renin. So it's the afferent arteriole and the distal tubule and that connection right where they come together. So this is an up close of that. So afferent arteriole, this is the distal tubule, and then this area right here is where the renin is released. And the renin is very important because it's a protein that is released into the blood. And this is a flow chart showing, so here's renin coming out of the kidney, and it combines with angiotensinogen in the bloodstream. Angiotensinogen is released by the liver. And the renin causes the angiotensinogen to have a piece cleave off of it. That's what produces angiotensin 1. And then angiotensin converting enzyme, which is on this endothelium. So this angiotensin 1 is in the bloodstream. And then angiotensin converting enzyme, which is on endothelium, and it's mainly in the kidney and the lung. It's combines with angiotensin 1 and causes angiotensin 1 to change to angiotensin 2. Angiotensin 2 is what triggers the adrenal gland, which is sitting right here on the cranial pole of this kidney, to release aldosterone. So that's why renin is so important. And then aldosterone is going to trigger sodium and water reabsorption by the kidney. So the whole purpose of this is to help the body keep normal elevated levels of sodium to a normal point, and to help keep blood volume up. So these are just 4 factors that control renin secretion. If there's decreased pressure in the afferent arterioles, so remember that vessel that's going into the glomerulus, that's going to cause renin to go up. So remember, renin increases aldosterone eventually. So anything when aldosterone goes up, sodium goes up. So anything that is going on in the body that needs to tell the body to make more fluid or to increase sodium will tell renin to go up. So sodium chloride concentration when it's low in the distal tubule. So remember, that's the other part that butts up against the juxtaglomerular apparatus. So when sodium and chloride is low there, renin goes up. And then sympathetic nerves can stimulate renin to increase. And then angiotensin II, which is what tells aldosterone to be released, it can also tell renin to be released. So it's a very kind of complex in a way, that kind of cyclical process that occurs. So after all that, the one adrenal gland says to the other, dude, you have no idea how tired I am. And the other one says, of course, you're telling me. So those are the adrenal glands there that look completely exhausted. So this study that was done trying to figure out the aldosterone levels in these dogs, and do these dogs really have lack of aldosterone, these atypical Addison's dogs. So back to how can sodium and potassium be normal if aldosterone is low? Because it really shouldn't be. In humans, there's evidence that there's an increase in renin, and the increase in renin is actually compensating for the inability of the zona glomerulosa to release the aldosterone. There's also was a theory in this paper that maybe aldosterone is actually not low, but the ACTH stimulation test that's done to measure aldosterone. So the same test that's done to measure cortisol is also done to measure aldosterone. Maybe that 1 hour period is just not the magic period of time to detect these dogs' aldosterone level. So the study looked at 15 minutes, 30 minutes, 45 minutes, and it looked greater than 60 minutes. There's a little mistake there. And found that there wasn't, they did not find any variation in the aldosterone levels. So they felt that the 1 hour period of time was appropriate to be doing this test in. So there's other possible mechanisms for having normal potassium and sodium without aldosterone. There could be a higher than normal tubular flow rate, with the potassium being delivered to the collecting duct with a greater concentration. And then there also could be that the distal tubule is got increased sensitivity to aldosterone. The receptor has been upregulated, so maybe the adrenal gland isn't releasing very much, but maybe the tubule has become more sensitive to it, and that allows the body to conserve the sodium. So therefore, your electrolytes can be normal. And then there also might be an increased sodium intake occurring, so in the diet, possibly. So I think this could be something that happens more in humans. But in dogs, a lot of our patients are getting salty treats, so the increased sodium intake is potentially helping maintain the electrolytes. So other possible reasons for normal electrolytes in these dogs, they could have some form of other illness occurring. Hypothyroidism has been shown to mask electrolyte changes. This is in a textbook. I could not find much about why that might be happening. It probably has something to do with the decreased metabolic rate, but the reason is not really clear. And then what could also happen is a dog could have Addison's disease, so not atypical, but have regular Addison's disease, and then the dog is having vomiting and diarrhea, so it's losing potassium that way. Maybe it goes to a veterinarian, starts on some IV fluids, gets some supplementation, presents to another facility. You could technically have normal electrolytes just from losing potassium and from providing IV electrolytes to replace sodium. And then the dog looks like it has normal electrolytes, so then it may not be recognized. So what the future might hold is possibly, in humans they do renin and aldosterone testing. It just helps provide more detail as to what truly is happening at the physiological level in a human with Addison's disease. So renin testing may be something in the future in atypical Addison's dogs. I do really think that we will eventually someday have a test of renin that is more available. There are some universities that can run renin, but it's pretty rare to be able to find this test available. And we also might start doing more stimulation tests to check cortisol and aldosterone. So trying to measure both to get a better understanding as to what our patient really is lacking to know in the future what we might have to replace. And then there also could be more of an approach of doing ACTH levels, so that secondary hypoadrenocorticism where the ACTH is not being released by the pituitary gland. If we measured an ACTH level in our patient, we could diagnose that because it would be low. And in a Addison or atypical Addison, so the primary hypoadrenocorticism, the ACTH level is elevated. So ACTH level can be run. Michigan State does perform it. It's just a very labile test, so you have to draw the blood immediately, have it on ice. It's one of those that you know, when you get your result, you hope that you got something accurate, so that's why it's been difficult to do in the clinics. Okay, so I wanted to talk about this patient that got me intrigued about atypical Addison's disease, and this is Mac. He's an 8-year-old neutered male golden doodle. This went on for 16 months. Mac really did present multiple problems, which I'm going to go through. So Mac presented April 13th, 2017 here to Knives, the emergency service. The reason why the owners brought him was he was having hematochezia and he'd had one episode of vomiting. So very common problems to see here on emergency. He'd also had a history of having some skin problems, and he'd recently been on a limited ingredient diet change, and he'd had some weight loss. So I think the thought process, well, maybe what the diet change led to some of his symptoms. He had a CBC in chemistry. There was a mild neutrophilia. He had a mild non-regenerative anemia, and he did have low cholesterol. So just to give some idea about his cholesterol, the range is, the low end of the range is 110, and the lowest he went down to was 74. There was times over the course of events that his blood work was measured and he was normal cholesterol, and another time that he was 90. So abdominal radiographs were performed, and he did have a nodule seen in his spleen. At that point, he was diagnosed with HGE and suspected GI ulceration, and he was given some Panicure, and the plan was to recheck in a week. He was also put on some other supportive medications. So this is the X-ray, and this was the spleen nodule right here. So the big question was, is that significant? So April 20th, he had a recheck, and his symptoms were resolved. He was improving, he was feeling better. His chemistry, 17, was all normal. His complete blood count, he had a non-regenerative anemia. It was normocytic, normochromic. It wasn't a very severe anemia. His hematocrit was about 34%. Hemoglobin was 12.8. He had white blood cells of 18,000 or so. Lymphocytosis, about 6,000. And then the neutrophils were high and normal, about 9,500. So the concern at this point became the spleen nodule. So the lymphocytosis, the worry was, is there some form of lymphoma occurring in this golden labradoodle? And I was trying to remember his breed, his breed combination. And is there some form of lymphoma occurring in him? And is that why he is having a lymphocytosis? So he came in to see internal medicine, and as I'm taking the history and talking to the owners, as I'm sure you know, the more people that the owners talk to, and I know you technicians really do feel this a lot because you're oftentimes the first people talking to these owners, but the more we talk to them, more information we tend to get, and so each person that talks to him gets more information typically. So discovered that he was being fed a raw egg every day and a cup of milk. So I thought, well, maybe that was the reason why he had the hemorrhagic gastroenteritis. So I really was pretty much like, it's the raw egg, it's going to be the raw egg. So he was having this chronic skin problem, but the owners had since, at some point, they told me they'd been to Purdue Dermatology, and they weren't that worried over it, and they thought it was maybe a behavioral problem. So we did a complete blood count because I was worried about his anemia and his lymphocytosis, and sure enough, everything was normal. So I did an ultrasound, and his splenic nodule was just a hypoechoic nodule. It looked very quiet. It was just a little over 1 centimeter, so I didn't feel it was something to get overly worried about. But we did do ultrasound-guided needle aspiration and cytology. So it came back as lymphoid hyperplasia. And there was also a little bit of extramedullary hematopoiesis. So I told the owners, I literally like to recheck it in 2 months, just keep track of it, see if it's changing. I was taking a kind of less aggressive approach. Mac's owners were pretty aggressive pet owners, but they were willing to wait a couple months so they could see what it was doing. So a couple months passed and I see him again, and now it's a little bit bigger. It's 1.4 by a little over 1 centimeter. And so at this point I took 3 view chest x-rays. There was no abnormalities seen. And at this recheck, there's even more history. They informed me that he's had a history of seizures in the past. So this wasn't new history, this is just old history that they decided to share. And then he also has some new symptoms. He's having intermittent hyporexia, and he's also having mild lethargy. I did a thyroid test, T4 and TSH on him that was normal. So at this recheck, I did another chemistry on him, and the only change, so cholesterol was normal on this chemistry, the only change was albumin now is 2.1, and then his complete blood count was improved. His hematocrit was 39%, his reticulocytes were 42,000, so not a major regenerative response at that point, but all in all, I felt that his CBC was stable, and the white blood cells were normal. We also did a 4DX at this appointment that was negative, so I wasn't sure why the low albumin. I started wondering, well, my goodness, maybe the spleen nodule is more of a problem. Maybe there is still cancer occurring in him, or maybe there's some sort of parasite problem. So it was a little bit vague as to and hard to understand why. So the owners just wanted to get the spleen out and find out what it was. So he had a splenectomy. We were also able to accomplish more things during the surgery. He had a gastropexy, and then he also had biopsies of his stomach, duodenum, and jejunum. And at the time of surgery, there appeared to be some liver nodules, and those were biopsied. There was a study in 2013 that looked at liver ultrasound.